if you can just start, you can just start the stream also.
Yeah, I'm doing that. Just a minute, I'll let you know.
Bhupesh, is Dr. Mathur here?
We'll just call him and check, sir.
Yeah, sure.
Streaming should have begun. Just see.
Yeah, so the streaming is also live, sir.
It should be there. Just see. Okay. Okay. So in yeah, you can go live there. Okay.
So, hello everyone, good evening and good morning in the other parts of the world. I'm Rahul, I'm the director at Poornima Group and co-founder of Poornima University. It gives me immense pleasure to welcome you all on our, I think, 17th webinar of on public health issues, and in particularly, our focus is about the ongoing pandemic. So, Poornima University School of Public Health, along with Jodhpur School of Public Health, Mobile and Indic-Chain, are pleased to welcome you all. Uh, Before passing on the baton to Anil sir, I would just briefly introduce him and our relationship with Jodhpur School of Public Health. Dr. Anil is a global public health specialist, and he is the president and CEO of Jodhpur School of Public Health, and he's skilled in global health, healthcare, business development, and global management. And we have been associated with Jodhpur School of Public Health and Anil Sir from past 3 years. We are entering into our third year now, and pleased to offer masters and bachelor's programs in public health and hospital administration in Poornima University, alongside Jodhpur School of Public Health. Um, so over to you, sir. And I'm just checking that, yeah, so all our attendees are also joining in. And so now over to you, Anil, sir.
Okay, thank you very much, Rahul. Good evening, everybody in India. Uh, it's a pleasure to be with you all. Unfortunately, these are very difficult times for all of us globally. And before we start, I would be asking everybody to observe a silence for a minute, because we all have lost someone we know, a loved one or near one or people we know. So if we could just observe a silence and pay the respect. Thank you. I think not a single day goes without hearing that we have lost someone or someone we know very close who is really sick, actually. And we do not know when this is going to end, actually. And today, that's why we have Dr. Sitesh Roy, an expert trained in the United States and India. He'll be talking about a lot of basic things. He'll be answering your questions. There's a lot of misconception. He will be clarifying those. That's very important that as a trained clinician, physician who's seeing lots of COVID patients, talks us about the basics, which is sometimes basics are the ones which are very, very important. And as Rahul said, I'm from the Jodhpur School of Public Health. I wear several hats, but today I'm representing Jodhpur School of Public Health with my colleagues, Bhavna Sati, Dr. Jagdish Harsh, Dr. Arvind Mathur, who will be joining us soon. As you all know, clinicians are very, very busy, and they're having a very punishable schedule around the world, especially right now in India. Also joining is Praful Kalla, who is a dentist by training, trained at Tata Institute of Social Sciences and Public Health, was an intern with JSPH, and now he's based in Pune with ICICI. And he'll tell us what he does. And unfortunately, he has contracted COVID. He's recovering. My colleague Kandar Mathur will be joining us from Jodhpur. He is a dentist by training, did MPH with us. He got reinfected. He'll be talking about his experience. And my colleague Ashish Manocha will be joining from Poornima University in Jaipur. He's the head of the Department of School of Public Health at JSPH and also Jaipur. He'll be discussing on the challenges he's facing to set up the vaccine drive at the Poornima campus. I would be really happy if you all in the audience send us the questions, because Dr. Sitesh Roy is with us today, and he has tremendous experience in infectious disease, immunology, allergy, and he's seeing a lot of these patients from all over the country. The consultations are coming throughout the day and night to him. In fact, yesterday I was also consulting him for someone I knew had got infected and wanted some expertise from him. And that person is based in a village in Rajasthan. So I think we'll be discussing all this, and I think it's very, very important that you bring up all these questions. No question is a stupid question. Every question is important. And I think as a physician, he would love to answer and be honest to the physician. And I think without taking much time, I just want to discuss the flow of event and go to next steps. So Dr. Arvind Mathur will be joining us shortly. He'll give his expertise. He will be in and out. Bhavna and I will be moderating. So I've given the introduction of everybody, and I will continue off and on. Bhavna will introduce once once the plenary session is over. She will be introducing Praful, Kandarp, and Ashish. She's working very closely with them. And Jagdish, my colleague, who's the founder, director, chairman of the Mobiloid Incorporation globally, and with Indic-Chain. He would be the discussant. He has 20 plus years of experience in public health. We started to work together during HIV/AIDS. And most of us here on the screen, you see Professor Arvind Mathur, Bhavna, Jagdish. We all have worked together in the HIV/AIDS era. And it still continues. And we have learned a lot from AIDS now, which we bring to COVID-19. And I give to Dr. Mathur to, just give some comments or any update he wants to, and then we'll go to Dr. Sitesh Roy. Welcome, Dr. Mathur. And maybe he's just joining. So maybe I think he will probably will ask him some questions and get his expertise a little bit later. So over to you, Dr. Sitesh Roy. It'll be very good if you could introduce us a little bit about what you've done in your academic careers in the United States and in India, and what kind of patients you consult and see in Bandra and Mumbai. And over to you, Dr. Roy.
Thank you, Dr. Anil, for firstly inviting me to this program, and secondly also specifically bringing me back to this platform. We did the first one with the no tobacco end game, and now this one. So as you rightly said, I'm an allergist, immunologist, and asthma specialist. I take care of both children and adults, and I have had about 10 years of practice in the US before I came back to India in 2011. And since then, I've been back here in India practicing both adult and pediatric allergy, immunology, and asthma. Immunodeficiency is also an area that I cover, autoimmune diseases. And since COVID came up last year, it's been a very active area of interest and work for me. Given that this has really taken over all of our time, space, and energy. The whole world is currently battling it, and I think that that's really something that we all realize is something that will stay with us for a little while, like we will speak. So what I would like to do is I have a short presentation that I've created about this disease. And should I begin now? Would that be fine?
Yes. Yes, please.
Absolutely, I think. Yeah.
Okay. So as the topic says, we are discussing report negative but COVID-19 positive. This is something that we see quite often, and I will just go through a little basics of what this whole issue is and what we are dealing with right now. So we know that the SARS-CoV-2 virus is not technically new to the human world, because SARS, which came in 2002, 2003, and then MERS, Middle East Respiratory Syndrome, which came in 2011-12, really gave us a taste of what these diseases could do. And they also led to acute respiratory distress syndrome, ICU admissions, deaths, but they were short-lived in terms of their timeline of what they did. This virus, on the other hand, though much bigger than the SARS virus, is much more efficiently transmissible. So much so that those two infections, SARS and MERS, never went from an asymptomatic person to another human being, whereas this virus has very clearly shown us that it can easily give asymptomatic or pre-symptomatic transmission, is very stable about the outside the human body. The other viruses had some predilection, and the old coronaviruses, the HKU, the EL64, these have had a tendency to be more prevalent in the colder months of the year. But this virus has shown us that whether it be summer, monsoon, winter, it does not care. It continues to transmit and transfer. It doesn't know barriers of boundaries of countries, borders, ages. We knew that kids were getting much less affected in the first wave, but in the second wave, we clearly know that children and young adults are hugely getting affected. So this virus is constantly mutating, changing itself, and becoming more and more efficient in causing infection and certainly taking a toll on our health and healthcare systems. So with that kind of a background, knowing that we are really up against a strong foe, we've all heard about the ACE2 receptor, which is where this SARS-CoV-2 binds. Now, we always thought that this was a respiratory infection, but interestingly, these receptors are present right from the respiratory tract and the lungs to the esophagus, the food pipe. It is also there in our skin, in our epithelial cells, which line most of our interiors of the body, the colon, the ileum, the liver, the bile, the gallbladder, and the cells in it, the heart, the kidney, the bladder. We know that there's something called neuropilin through which it can enter the nervous system directly, which is why it causes loss of sense of smell by going straight to the olfactory bulb up in the nose and creating an infection there. From there, it can enter the entire nervous system, the brain, the spine, go pretty much anywhere it wants in the body and create a very potent immune reaction. We know that this first began actually in November 2019, though this is data that has been quote unquote suppressed. I won't put it that way, but there were 60 cases by the 20th of December. December 31st is when WHO office in China got to know that this is a unusual case of pneumonia that behaved like SARS. First case outside China came Jan 13, 2020 in Thailand. The Chinese officials first confirmed human-to-human transmission Jan 21st, 2020, and India reported its first case in Kerala on Jan 30th, 2020. From there, we have clearly gone to several million cases and about 2.5 lakh deaths. As you all can see here, the worldwide global cases today stand at 156 million. The cases in India stand at about 21 or 22 million. The deaths stand at about 3.27 million. And clearly the toll is rising. Now, one very interesting fact that I'll mention to you, we doctors who have been working in this field from the beginning believe that if these are the documented cases, the real number of people who've been exposed is probably 5 times or maybe even 10 times higher than that. Because for every diagnosed case, there are multiple undiagnosed cases that may never get tested. So we really are looking at almost officially 2% of the world population being exposed to COVID. And if we look at it unofficially, probably close to 10 or 20% of the world population being exposed already to this virus. We know that it transmits through coughing and sneezing. That's what we've always been told, aerosol transmission. But we as immunologists have been saying, based on the behavior of this virus, that this virus certainly has airborne transmission, which means you don't need large particles coming from coughing and sneezing. Because we knew from way back when that super spreaders who had no cough and sneeze and who were either singing at a church or at a karaoke bar, or they were talking loudly in a pub, were also transmitting this disease to 10, 20, 40 people at a time. And now finally the CDC has come out just a couple of days back and said, yes, this virus is transmitted by airborne transmission also. We were very worried about contact transmission, but fomites and surfaces seem to be less likely to be transmitting this virus. And direct contact certainly can. Feto-maternal, what is called transplacental transmission has also been seen, though less common. This disease can present clearly as an asymptomatic illness. It can come as with symptoms, upper respiratory, fever, lower respiratory, muscle aches, body pain, weakness. ये सारी चीजें जो होती है, शुरुआत होती है एक सिंपल गले में खराश से लेके कभी थोड़ा सा बुखार, कभी थोड़ी खांसी, कुछ लोगों को एक दिन का बुखार आता है, उसके बाद कुछ नहीं रहता और अचानक से उनको खांसी और दम शुरू हो जाता है। तो ये वायरस का कोई स्पेसिफिक तरीका या प्रोसेस नहीं है, ये कुछ भी कर सकता है शरीर में और यही इसका सबसे यूनिक प्रॉपर्टी है। ये कभी-कभी बिना बुखार के भी आ सकता है। लोग लो रिस्क हो सकते हैं, हाई रिस्क हो सकते हैं। इसमें पेट के मैनिफेस्टेशंस जैसे कि उल्टियां होना, दस्त होना, शरीर पे लाल लाल चट्टे आना, हाथ पैर नीले पड़ जाना, छाती में दर्द होना, कुछ भी हो सकता है, आंखें लाल होना, कंजंक्टिवाइटिस होना। This disease really has a myriad of manifestations that we see. And so much so that the WHO back in November 2020 said that if you're having shortness of breath, you're having loss of speech, mobility, confusion, which would be like symptoms of a stroke, which means because we know that it can cause inflammation of the meninges and the brain, chest pain, because we know it can give heart attacks when it goes through the microcoagulopathy and the clotting that this disease causes. But the most common symptoms still remain fever, cough, tiredness, fatigue, loss of taste, and loss of smell, sore throat, headache, aches, pains, diarrhea, rashes, red irritated eyes, I already mentioned. Why do I mention this? Because even though a report may be negative, knowing that someone has any spectrum of these symptoms should raise certain red flags, as we will see. This is a very important slide because knowing the frequency of these symptoms, taste या smell जाना 80% माइल्ड केसेस में होता है, खांसी 84%, बुखार 80%, मसल या जोड़ों में दर्द 63%, थकान महसूस होना 62%, सर दर्द होना 60%, दम लगना 57%, कफ पैदा होना 33%। ये इंपॉर्टेंट है क्योंकि हमेशा देयर इज नो बलगम नहीं आती, सूखी खांसी होती है जनरली, बट बलगम वाली भी हो सकती है। बुखार के साथ चिल्स आना, कपकपी आना 63%, डायरिया होना, दस्त होना 48%, सोर थ्रोट होना 14%, वॉमिटिंग होना 13%। जैसे आप देख रहे हो ये सिर्फ एक रेस्पिरेटरी वायरस नहीं है, ये पेट और आंतों को भी अफेक्ट करता है, लिवर को भी अफेक्ट करता है, आगे के स्टेजेस में बॉडी के किसी भी ऑर्गन को शट डाउन तक लेके जा सकता है। सिर्फ ये नहीं, लोग बोलते हैं कि क्या हुआ, सिर्फ सर्दी खांसी है, होके चला गया तो कोई तकलीफ नहीं है। मत सोचिए ऐसा, क्योंकि एसिम्प्टोमेटिक या माइल्ड इन्फेक्शन भी लोगों को 2 महीने, 4 महीने, 6 महीने बाद भी परेशान कर रहा है। इसी को हम पोस्ट कोविड सिम्टम्स और लॉन्ग कोविड बोलते हैं। लॉन्ग कोविड में थकान लगना, क्वालिटी ऑफ लाइफ चले जाना, मसल्स में पेन, मसल वीकनेस, जॉइंट पेन, दम लगना, नॉर्मल एक्टिविटी से थोड़ा ज्यादा करने पे पीपल गेट ब्रेथलेस in the post-COVID or the long COVID syndrome. Some have persistent oxygen requirement. I'm right now treating one patient long distance who has recovered the co-infection, but oxygen requirement still stays at 1 to 2 liters per minute, and he has no signs of active infection anymore. Anxiety, depression, sleep disturbances. Just today, I have seen 2 patients who say that they can't sleep more than 3 or 4 hours. And it is very disturbed sleep, very broken sleep. They never had this problem before they had COVID. Post-traumatic stress disorder. जो घबराहट, जो डर, जो टेंशन, जो एंजाइटी एक इंसान गुजरता है अस्पताल में अकेले, परिवारजनों से दूर, इस प्रोसेस में उसके ऊपर जो साइकोलॉजिकली गुजरता है, उसको पोस्ट ट्रॉमेटिक स्ट्रेस डिसऑर्डर भी हो सकता है। Cognitive behavioral changes, brain fog, चीजें याद न रहना, people forgetting things, unable to remember simple things that was a piece of cake for them before. So memory disturbances, headaches, palpitations and chest pain, again very common in those who have had severe COVID problems. Thromboembolism, that means blood clots, chronic kidney disease, hair loss. You would think that this is a small thing, but ask to a young woman or a middle-aged woman or any woman if she starts losing hair in bunches literally after she has COVID, just like we would see after typhoid. So this is not a disease that you take lightly and just say, oh, it's like another cold, it doesn't even exist. I've heard these videos and seen these videos from around the world, not just people in India who say that COVID is nothing. It is something, and you need to respect this virus and this disease. We'll now come to the main mudda. जो सबसे बड़ा मुद्दा है कि टेस्ट और वो कितने रिलायबल है। तो ये बीमारी जब शुरू होती है तब पहले 5-7 दिनों में आईजीएम बोल के एक एंटीबॉडी बनना शुरू होता है 7वें दिन से, आईजीजी तकरीबन 7वें और 14वें दिन के बीच में बनना शुरू होता है, और उसके बाद ये ग्रेजुअली आईजीएम दूसरे तीसरे हफ्ते में डिक्लाइन होता है, आईजीजी राइज होता है और वो ऊपर रहता है। तो ये हमें बाद में के डायग्नोसिस में हेल्प करता है, बट acute stages में it is mostly something called rapid antigen test and something called RT-PCR test that is most important. Why are we even having this discussion? If the report is negative and you're still COVID positive, why should you worry? Because it is well known that at least 20%, I would say the number is higher, maybe 30-40% in India, symptomatic patients are testing negative. They can get very sick without knowing. Like I said, थोड़ा सा बुखार आया, जल्द से टेस्ट कर लिया, टेस्ट करने के बाद नेगेटिव आया, बेधड़क घूमने लगे, फिरने लगे, खाने पीने लगे, सब करने लगे, अचानक बीमारी बढ़ गई और पर्सन फिर अस्पताल का बेड ढूंढ रहा है। 30-40% केसेस एसिम्प्टोमेटिक है, तो ये मिस हो गए। ये लोग अपने घर में, परिवारजनों में, अपने ऑफिसेज में, वर्क प्लेसेस में ये वायरस को स्प्रेड करते हैं, क्योंकि उनको लगता है कि वो नेगेटिव है, टेस्ट नेगेटिव आया। ऐसे हेडलाइंस ऑफ रिपोर्ट्स जहां पे पर्सन को नेगेटिव रिपोर्ट आया है, उनको नॉन कोविड हॉस्पिटल में जस्ट लाइक दे आर हैविंग अ नॉर्मल कोल्ड कफ एंड निमोनिया, दे आर बीइंग ट्रीटेड, and before they know it they have infected many people at the non covid hospital, plus including nurses, doctors, support staff at the hospital, cleaners, etc. And besides that, they don't get the quality of and the level of care they should for their covid infection, and before they know it people have lost family members due to that. They've been having delayed admission because they thought their report was negative. They've been denied admission because they didn't have a COVID positive report. So though they were having cough, breathlessness, they had oxygen requirement, they were told your RT-PCR is negative. Sorry, we won't admit you. Horrible situation, which has only today, okay, on May 8th, 2021, with the health ministry directive, this you see this headline, COVID positive result is no longer mandatory for admission to a COVID hospital or for COVID care. Inappropriate treatment obviously would be the outcome if you had a COVID negative report, but COVID positive by symptoms. अब ये क्यों होता है? पहला कारण, viral factors. We all know that when COVID-19 first hits us, it has an incubation period during which the virus makes many copies of itself and spreads inside the human body. This incubation period can be 2 to 14 days. It manifests adequately in terms of symptoms generally by the 5th or 7th day of the infection cycle, when the person gets either thakan, weakness, fatigue, myalgia, headache, little scratchy throat, itchy throat, little fever. If this person was tested sooner in the early stage when the viral load was low, then this person would have a negative report and they would not realize that later on they were going to be positive. So it's the timing of the test in relation to the virus. Even a week after infection, there are false negativity rate of even 20%, even in the US, meaning 1 in 5 people who actually have the virus and the infection will test negative. The researchers estimate that those tested for SARS-CoV-2 in the first 4 days of infection, 67% of them would come back negative even if they had the virus, because the viral load is not high enough. 3 to 5% of the results may be false positive, which means they don't have the infection, but still they were detected, a whole different topic. We'll take the human factors of why the test comes negative. Fear, anxiety, panic. Person goes at the earliest possible time, like they just went past someone, or in their Arogya Setu app, it came up that you were in red. Boom, they're at the lab getting the test done. It's too early. The virus has not yet multiplied. The test is going to come negative. You may go into the testing center. You could walk out of it. Your test is negative, but outside you walk and someone happens to be there who is highly infective and releasing a lot of viruses, and you're waiting maybe in a waiting area or at work or somewhere, and now you contract the virus. So you contracted the virus after you took your test and you still come back positive. So this has nothing to do with the virus, nothing to do with the human factor, the test factor. It is just a practical situation. You may have taken a COVID negative report before you boarded your flight or went on a train or a bus. And in that area that you were in, you then got exposed and the virus got into you. You're carrying around a negative report thinking that you're safe, whereas the virus can still get you. And which is why putting your guards down in front of this virus is really not a smart thing. We'll come to the test factors, and these are the most important. If the sample is not corrected properly, the nasopharyngeal swab requires a very deep insertion, almost 6 inches of the swab to the back of the nose where the throat begins. And most swabs are taken by just putting it up the nose and turning 1 or 2 times. You put it all the way back and turn it 3, 4 times, rotate it. Not a very comfortable procedure. And imagine when you do that, people sneeze. And so the person collecting it also is scared. So the right collection of the sample is so very important. Next comes the transport and processing of the sample. If it is not transported or processed in the right way, you can miss errors in extraction and amplification. The way the test runs, you take the viral RNA from the sample, from the secretions, you extract it, and then you put it through a chain where it gets multiplied and amplified so it can be detected. That's how you get the CT count, the cycle time count. The higher the viral load, in a few cycles, you will detect the virus. The lower the viral load, you will require more cycles to detect the virus. So your CT count may be 25 or 30 or 32. Whereas if your viral load is high, your CT count would be 10, 11, 12, 7. Error in reporting samples. Samples are not reported correctly. Names can get mixed because volumes are so high, data can get mixed, numbers can get mixed of patient numbers. Suboptimal sensitivity of the test. We know that the rapid antigen test has a sensitivity of 50 to 60%. Should be more like 90, but in practical, it's 50 to 60%, which means half of the cases can be missed in a rapid antigen test, which is why all the guidelines say that if you have a negative rapid antigen test, you should follow it up with an RT-PCR if you have a high level of suspicion of your symptoms. You should never only rely on a rapid antigen test being negative if the symptoms are there. Quality control of the test kit. And again, for the RT-PCR, the sensitivity is around 70%. We can miss a lot of cases. They're also up to 20, 25, 30%. And so in that situation also, we have to remember that the test can be repeated. You could repeat it after a couple of days. You could do a better job at collecting the sample, transporting it, and getting it run. Maybe the viral load will be higher. Sometimes if you do it too late in the virus, so past day 10, the virus may have left the upper respiratory symptom and mostly located itself in the lower respiratory system, and you may miss it. Just going back to the viral factor, one very important thing to mention, people always say that now that the mutants or variants are there, the RT-PCR or the rapid antigen test can miss it. The rapid antigen test may have a higher chance of missing a mutant or variant, but RT-PCR doesn't only measure the spike protein or the spike protein producing RNA. It also measures the envelope protein producing RNA, the membrane protein producing RNA, the nucleocapsid RNA. All of these are manufactured by the virus through these different genes, and it picks other ones too. And so the chance of RT-PCR getting affected by a mutant or a variant is lower. But with the rapid antigen, certainly a possibility because not all the antigens may be represented. The viral detection timing. Early in the infection, virus may not have reproduced enough. False negative rate of PCR tests on the day of exposure is 100%, क्योंकि पहले दिन पे कोई वायरस है ही नहीं, तो आप डिटेक्ट क्या करोगे? अभी वो मल्टीप्लाई कर रहा है, अपना बना रहा है, अपना कॉलोनी, अपना संघ, अपना ग्रुप. 38% 5 दिनों के बाद, क्योंकि काफी सारे लोग फिर वायरल प्रोड्यूसर्स रहते हैं बाय डे 5 और नंबर ऑफ false negatives kam ho jate hain. The rate decreases to about 20% after 3 more days. So really, as we see, the key timing is the first 5 days of symptoms. If in the first 5 days of symptoms, maybe even the first 3 or 4 days of symptoms, if the test is done, the chance is higher. Test factors. We know that the ICMR since July 2020 has 38 quality control labs that are designed to monitor the 2,400 labs across India that do RT-PCR testing. Ideally, a mix of positive and negative samples should be randomly picked up from these labs and retested. Was this ever done? Yes. Is this being consistently done? The answer is no. So clearly we know that there can be errors there. I shall not even get into the fact that there are false reports being given, tests not being run and reports being given. Those are scams. That is not my place to be saying those things, but they are unfortunately happening in places. So please, 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 if you have a high level of suspicion and you get a negative report, please go test somewhere else also. All RT-PCR kits include internal control to safeguard the scenario when no RNA is there, which may lead to a false negative. So means the sample is not right, tissue is not there only. So there you actually have to use a human housekeeping gene to know that the test collected the right sample. But unfortunately, most labs have been using an exogenous artificially added RNA template to know that the test was done correctly. And again, these are cheaper, and 75% of the RT-PCR kits in the Indian market use the exogenous control rather than using the person's own human housekeeping genes, which would naturally be present in the sample you've collected to know that the sample is right. Over 200 RT-PCR kits have been approved in India against the emerging mutations. A test may return false positive if the mutation occurs in a segment of the gene that is being assessed that is not represented in the test. But as I said, this is a less of a chance for RT-PCR. The price of RT-PCR kits have fallen from 1100 to down to 40 rupees. Yes, I'm not joking. And the corresponding cost in the lab is 4,500 to 800. With the drop in price, could the quality have dropped? It's a possibility. I'm not anyone to answer that. That's up to the administratives and the government authorities to look into that. Cycle time cutoff of 35 or lower. Some labs or some states were trying to keep it at 25. Bad idea. Below 35, definitely want to know if that person, the chance of transmission is lower above 30, but we still want to look at 35 and lower for a positive. What should you not do if your report is negative and you still have symptoms? Don't forego your physical distancing, your mask wearing, your hand washing, your respiratory and cough etiquette, your mitigation features, wearing your mask even when you're around your family and co-workers, because though your report is negative, if you have symptoms, you should ideally be quarantined. And if the contacts remain without symptoms, they can be tested as per capacity if there is a need to happen. This is mostly talking about contacts who have not yet developed a whole lot of symptoms. They can be retested if symptoms develop later, if they were screened to know because they were in contact with someone. But for someone who has symptoms, the top part of the slide is very much relevant. What not to do if you have a negative report but have COVID symptoms. 1 in 5, this will happen. Get a confirmation RT-PCR if needed. Continue to wear a mask. Stay in a separate room in a home if you can. Do isolate till we can get more clarity on how the symptoms are going to progress. So this is where human and personal responsibility comes in. Don't be such cavalier and nonchalant that you'll just go out and meet people and party and spread it to more people. Bad idea. The US FDA says consider a negative result in combination with the clinical observations, patient history, epidemiological information. Consider repeat testing if COVID is still suspected after receiving a negative report. Remember, the case history never lies. A good, astute physician will pick this up. Blood markers don't lie. So if you do the COVID test along with certain blood tests, you've heard of CBC, CRP, LDH, ferritins, these will tell you if the infection is there, even if the RT-PCR comes negative. And we definitely know, and we have all as physicians used this, HRCT, a high resolution CT scan in such situations where someone is coughing or getting breathless or getting any of these things, the HRCT may be positive. We know that in asymptomatic people, up to 20% or 30% of them have changes seen on the high resolution CT scan also, according to some studies. So done at the right time, not too early, not too late, at the right time, in a situation where the COVID, the RT-PCR or the rapid antigen is negative, suspicion is high, HRCT can be invaluable in diagnosis. The CDC says that you should at least quarantine for 14 days, but consider 10 days if you haven't experienced symptoms. The agency also says that it's probably safe to leave the home after 7 days if you have 0 symptoms and have a negative result. But understand the personal responsibility. 7 days, you still have to take precautions so that you don't spread it to others. And the most at risk is your own family, friends, and loved ones. Differentiating COVID from allergies, viral infections, this is helpful. You know, if you all want, these can be accessed. You all can get in touch with us. These are there on my YouTube channel. I've done a lot of videos where I've presented some of these things but recognize the differences, but understand that even a common cold is not just a common cold, even an influenza is not just an influenza, even an allergy is not just an allergy during the COVID pandemic. Take everything with a pinch of salt, have a high level of suspicion, don't get paranoid, but definitely if you have a spectrum of symptoms where the fever is with the cough and there is some muscle ache and there's a loss of smell and taste, and you have some other symptoms and they've been coming and going, they don't often happen all together, then definitely consider testing. Same thing with asthma. You have to realize that some of the other bodily symptoms are not there with asthma because these are common respiratory problems that we see. And with the coming monsoon season, people's allergies are going to get flared up because of molds and indoor allergens, dust mite, cockroach. People's asthma is going to flare up because of the humidity, the increase in barometric pressure. So differentiating that, we did that last year, we'll have to do that this year also. Recognize that the spectrum really helps. There are very good guidelines from ICMR on how to manage mild, moderate, severe disease. Mild, moderate, severe disease definition is something that your physicians will know and you also would know, and getting the right level of care is so important. The WHO characterizes the risk categories into non-severe, severe, and critical. Oxygen levels have become very common to measure, done correctly, respiratory rates, and then signs of distress, and then clearly people requiring more support. Ministry of Health and Family Welfare, good numbers to have, toll-free numbers. Your states will have numbers in your individual states, just like we have COVID war rooms in Maharashtra and Mumbai. You all would be having things in your area. Do take help from there if you have doubts and questions. Stay safe, stay informed. Remember that this too shall pass, but till it does, take all precautions and keep yourself and your families safe. If anyone needs to get in touch with us, these are some of our numbers. For me, my clinics, my online consultations, my YouTube channel, Dr. Roy Health, has over 80 videos related to COVID and different aspects of health. Mucormycosis, getting a fungal infection in the sinuses and going into the eyes and brain, which are literally killing people these days because they get too much of steroids during their treatment in the hospital, which is not appropriate. I had put out a video for it about 3 months ago, 3.5 months ago. So do visit my YouTube channel if you can. Subscribe. Videos come up at least a couple of times a week. And with that, I shall end my part of the presentation and be open to taking questions. Thank you very much once again to Jodhpur School of Public Health, Dr. Anil Purohit specifically, and to the entire Poornima University team for inviting me and having me here. Thank you very much.
Thank you. Very, very good presentation, Dr. Roy. I'm sure there'll be lots of questions, but I have two questions, if I may ask, and I could always talk to you later, but I need to give opportunity to others. So to avoid heart attacks, normally in the United States, 40 plus males, they normally take 81 milligram aspirin enteric-coated. I also heard actually that during COVID, a lot of primary care physicians in the United States are asking to take 81 milligram enteric-coated aspirin. Plus, looking at the history of the 1918 Spanish flu, it was widely used actually. So what do you recommend to your patients and what would you give us as a message? Because there's a lot of misconceptions, especially people I know in India, that aspirin is not good actually. So I'd like to hear from you.
Sure. So I would say that aspirin has certainly its benefits when it comes to, as you rightly said, ischemic heart disease, myocardial infarction prevention, and has been used very long time. Initially, people were scared of using it because they were thinking that you could actually induce certain reactions for people who have respiratory diseases and have what is called aspirin sensitive respiratory diseases. They also had concerns that you may suppress some of the manifestations of the disease. And I think the main technical issue that had come up was that it's really not a platelet issue that causes the coagulation. It's more of a coagulation factor defects and deficiencies or exacerbations that cause this problem. And hence really the apixabans and the rivaroxabans and the low molecular weight heparin became very popular and should be rightly for managing in-hospital cases and maybe even immediately post-hospitalization. But when you're talking about outpatient management, using agents like clopidogrel or aspirin, I don't think it could really hurt anyone, frankly. And I truly believe that for whatever it is worth, if you have individuals who are high risk, if you feel that this person may be at risk for getting an MI or getting a kind of a stroke or anything like that, I don't think that 81 milligrams of aspirin really could hurt someone as long as you screen them, as I said, for allergic exacerbation of respiratory diseases or aspirin exacerbated respiratory diseases, and also know that they don't have any risk of gastric ulcers or bleeding. So I would say that it still has value. I am certainly using it in my patients when I'm treating. And, unfortunately, with the bed situation and everything in India, I'm managing people on oxygen at home because I've managed people with as low as, Anil, I know you're going to get a shock, 55% oxygen levels at home. Okay. And luckily we've been able to get oxygen to them and get it in the 80s and then eventually into the 90s. But in these patients where I can't use injectable drugs at home, low molecular weight heparin or claxane or any of these drugs, I would certainly use in a heartbeat clopidogrel and aspirin for whatever it is worth, recognizing and giving people the risks, benefits, and everything in advance. So I am for it. I know many people may not agree with me, but oh well, in a pandemic, you do whatever you can to save your patient's life.
All right, thanks. Dr. Mathur, do you want to comment on that?
No, I agree with Dr. Roy that, of course, the choice would be using some anticoagulant in a certain stage of the disease, but
Absolutely.
it's not possible because over here also in our practice, we find it difficult to give injectables at home because they just don't know how to inject, and they getting somebody to do is also not possible. And availability of the oral these direct oral anticoagulants like rivaroxaban or apixaban, the availability is also an issue, and to some extent, cost and availability is also an issue. So over there, I would also prefer, and usually we do that we add either aspirin or clopidogrel, or even Dr. Roy, we can use either of them instead of using the dual antiplatelets. No?
I completely agree. We could use either also.
Yeah. So that is one thing. And as has been mentioned by Dr. Roy, that this issue of test negative and having COVID is very commonly seen in clinical practice with people coming with advanced pneumonia, but still their test is negative or so. So clinical evaluation remains the main thing for uh, for your action and for your planning or for your decisions, basically, because and I feel that in present scenario, just syndromic management of COVID is essential instead of waiting for the test, basically, because that is what anybody coming with these symptoms suggestive of COVID, better to treat them as COVID and get them for 15 days and isolation and management plan rather than waiting for the results.
I would very much agree with you, Dr. Mathur, on that. And I've had to do that. Means in a place like Delhi, there is a 4-day waiting period for an RT-PCR result. Place like Delhi, okay? Place like Mumbai, I've had 48 hours waiting. I cannot wait to start an antiviral on my patient for 48 hours or 72 hours or 96 hours. I'll have missed the window in which I can make a clinical difference for that patient. And that's why the blood biomarkers are so important. You get a blood report for a neutrophil lymphocyte ratio comes back the same day within hours. And you know if it is turned around that you're high risk. Your CRP comes back within a couple of hours. Your LDH, your ferritin comes back. You look at all those things and you begin the therapy. You don't wait for the RT-PCR to come back. So I 100% agree because viruses respond best if the drugs are started early in the disease. So when I see all these people chasing after remdesivir on day 10, day 12 of the disease, you've already missed the window. The window was 5 to 10 days, which is where it should have been used ideally. But again, there are people who shed till day 20. So there is value when someone is hospitalized or in the ICU or those situations. But I certainly feel that your point is very well taken. We don't wait for the reports, we start treatment before that.
Excellent.
Yes. So
So over to you, Jagdish. I think partly if you could bring up some questions which would help the general audience, lay population, maybe mixing Hindi and English. Basically.
yes. So I'll go in Hindi. So डॉक्टर सतेश रॉय एंड डॉक्टर अरविंद माथुर, आपने मेरे पास दो क्वेश्चन थे, उसमें से एक का क्वेश्चन तो इफेक्टिवली आपने आंसर कर दिया है, लेकिन मैं उसको फिर से बोलता हूँ। अभी जो रूरल पॉपुलेशन के अंदर जो बढ़ोतरी हो रही है केसेस की, और ये और बढ़ेगी, उस केस में टेस्टिंग का महत्व और बढ़ जाता है, क्योंकि आरटीपीसीआर एक तो कम है, और आपने बहुत अच्छी स्लाइड बनाई जिसके अंदर की टेक्निक ऑफ टेकिंग स्वाब, वो अपने आप में एक अर्बन सेटिंग्स में भी एक चैलेंज है, तो रूरल के अंदर तो ऑफ कोर्स है ही। और एंटीजन के अंदर भी जो टेस्ट अवेलेबल तो हैं, लेकिन एंटीजन और आरटीपीसीआर के बीच में इतनी ज्यादा बातचीत चल रही है कि एंटीजन को तो एक तरीके से लोगों ने नकार दिया है। और आज मेरा एक एम्प्लॉय, आज ही सुबह की बात है, वो मथुरा के पास के गांव में रहता है, उसकी वाइफ को कोविड लाइक सिम्टम्स हुए थे। उसने मुझे कांटेक्ट किया, मैंने कहा हाँ आप जाइए, तो कह रहे नहीं पानी चढ़ा दिया है, कौन टेस्ट कराएगा सर, आरटीपीसीआर तो होगा नहीं। उसको नाम पता था आरटीपीसीआर, उसको एंटीजन के ऊपर कोई भरोसा नहीं था, आरटीपीसीआर वहां पे अवेलेबल नहीं था, तो उन्होंने पानी चढ़ा दिया, ग्लूकोज चढ़ा दिया, बस। और ये जो हो रहा है, ये आपने उसका आंसर दे दिया है कि सिम्टोमेटिक और जो ब्लड वर्क के ऊपर जो है, उस पर सोशल मीडिया मार्केटिंग या सोशल मार्केटिंग होनी चाहिए कि जो कोविड डिजीज के जो मार्कर्स हैं ब्लड के, उसके ऊपर रिलाय करके अर्बन रूरल सेटिंग्स के अंदर इलाज को चालू कर दिया जाना चाहिए। वो चीज की मार्केटिंग अभी महत्व नहीं दिया जा रहा है, क्योंकि टेस्टिंग के ऊपर सारा देश बात कर रहा है। तो ये आपने वैसे आंसर कर दिया है, लेकिन ये अगर आप दोबारा बोलें। दूसरा क्वेश्चन है मेरा अर्बन सेटिंग से। मैं गुड़गांव में रहता हूं, और 2 दिन पहले सीडीसी की जो गाइडलाइन आई जिसमें एयरबॉर्न की बात चालू हुई, और आज फ्राइडे को ऑफिशियली आ ही गया, उसके बाद में मैं यहाँ पर कमेटी का मेंबर हूँ कोविड की, और सडनली सबने मान लिया कि एक्सपोजर हो गया उनको, क्योंकि उनके ऊपर वाले अपार्टमेंट वाले को पॉजिटिव है, तो उनको एक्सपोजर हो गया, क्योंकि एयर कंडीशनिंग जो है कॉमन है, तो उन सब ने अप्लाई कर दिया टेस्ट के लिए। तो हमने आज देखा कि जबरदस्त रिक्वायरमेंट आ गई आरटीपीसीआर टेस्ट की, क्योंकि सबने अपने आप को एक्सपोज मान लिया, क्योंकि हमारे यहाँ पे 570 अपार्टमेंट हैं, और उसमें से 75 ऑड क्वारंटीन में है, तो करीब करीब हर अपार्टमेंट कह रहा है मैं तो एक्सपोज हूँ, मैं उसके ऊपर हूँ या मैं उसके नीचे हूँ। उसके अंदर एडेड बात ये हुई है कि जो गाइडलाइंस आ रही हैं वो गवर्नमेंट के साथ में मिलके आ रही हैं, जिसमें ये लिखा जा रहा है कि आज ही आइए मेरे पास में, जिसमें लिखा है कि भाई आप अपना, अगर आप पॉजिटिव हैं तो आप अपना एग्जॉस्ट फैन नहीं चलाएं, अगर आप पॉजिटिव हैं तो अपने सीवेज के अंदर से भी ट्रांसफर हो सकता है, ट्रांसमिट हो सकता है, इसलिए बंद रखें अपने कमोड के ढक्कन को। तो ऐसी चीजें जो गाइडलाइन आ रही हैं हर अपार्टमेंट कॉम्प्लेक्स में डिस्ट्रीब्यूट हुई हैं, आज कल हुई थी और आज हुई है। उसके कारण सडनली टेस्टिंग के ऊपर लोड आएगा, जो कि फॉल्स टेस्टिंग होगी बहुत सारे लोगों की, वो अपने आप को एक्सपोज्ड मान रहे हैं सारे लोग। तो ये दो क्वेश्चन है, एक रूरल सेटिंग का, एक अर्बन सेटिंग का। डॉक्टर सितेश रॉय आपके लिए।
तो पहले तो रूरल सेटिंग का जैसे आपने बोला, हमने ऑलरेडी उसका जवाब दिया है। अगर आप रैपिड एंटीजन टेस्टिंग, प्लीज मैं एक स्ट्रॉन्ग वर्ड यूज कर रहा हूँ, फालतू नहीं है, वेस्ट नहीं है। 50%, 2 में से 1 केस तो पिकअप करता है। तो उसको आप अगर वो जब पॉजिटिव आता है तब वो पॉजिटिव है, उसमें कोई डाउट नहीं है। उसका स्पेसिफिसिटी जो बोलते हैं वो बहुत हाई है, 97%, 98% स्पेसिफिसिटी है। तो रैपिड एंटीजन को आप नकार मत दीजिए, वो टेस्ट वैलिड है। अगर वो नेगेटिव आता है और सिम्टम्स है, तब आपको आरटीपीसीआर करना है, या जैसे बोला गया आप साथ में ब्लड टेस्ट कीजिए, क्योंकि ब्लड टेस्ट आपके प्रोग्नोसिस, आपका बीमारी कैसे बढ़ने वाला है वो भी आपको बताता है। अगर आपका न्यूट्रोफिल लिम्फोसाइट रेशियो जो आपके ब्लड काउंट पे आता है वो अगर लो है, तो चांसेस है कि आप अस्पताल में या आईसीयू में नहीं जाएंगे, और वहीं पे आपका अगर एनएलआर रेशियो 3.5 या 4 के ऊपर है, आपका डिजीज लंबा चल सकता है, ज्यादा बीमार हो सकते हैं। तो सीबीसी, एक सिंपल ब्लड काउंट, एक सिंपल सीआरपी, एक एलडीएच, एक फेरेटिन, ये चीजें बहुत मायने रखते हैं आपके डायग्नोसिस में मदद करने के लिए। अगर आपके पास एंटीजन या आरटीपीसीआर नहीं है, रूरल एरिया में बेसिक ब्लड टेस्ट हो ही जाते हैं। और सेकंड, जैसे आपने बोला कि उसके ऊपर ट्रीटमेंट, अगर सिम्टम प्रोफाइल मैच करता है, बेसिक टेस्ट हो गए हैं, ट्रीटमेंट शुरू करना बहुत जरूरी है। सो आई थिंक दैट आंसर्स द फर्स्ट क्वेश्चन। द सेकेंड थिंग, सारी दुनिया एयरबोर्न ट्रांसमिशन के ऊपर क्रेजी नहीं होनी चाहिए. दिस इज नॉट समथिंग, ये ऐसा है कि अगर आपने अपने खिड़की दरवाजे खुले रखे, अपने स्पेस को एयर किया, स्पेस को एयर सर्कुलेट किया, तो आप उसको उतना नहीं फैला सकते. वी नो, हम जानते हैं कि अगर इंसान बाहर के हवा में, लोग वॉकिंग करने से डर रहे थे, जॉगिंग करने से डर रहे थे, रनिंग करने से डर रहे थे, जबकि क्लियरली प्रूव हो गया है कि कोविड आउटडोर एनवायरनमेंट में नहीं ट्रांसमिट होता. अनलेस आप पर्सन के साथ खड़े रह के बात करोगे 1 फुट 2 फुट की दूरी में, तो हो सकता है, वो भी अगर मास्क है तो वो भी कम हो जाएगा 80%. बट सेम वे, अगर आपने अपने स्पेस को एयर किया, एयर सर्कुलेट किया, फैंस चलाए, एग्जॉस्ट चलाए, सब किया, आपका एक्सपोजर उतना नहीं होगा. और कहीं से भी ऐसा नहीं माना जाता कि अगर आप एक्सपोज हुए हो तो आपको टेस्ट करना ही है, क्योंकि समझिए, ये वायरस का ट्रांसमिशन रेट नॉर्मल रेट में भी 2 to 3 पीपल है. चलो वेरिएंट के साथ, सुपर स्प्रेडर के साथ हाई है, लेकिन एक्सपोजर इज नॉट इक्वल टू डिजीज. थोड़ा तो कुछ सिम्टम्स के लिए रुकिए. आप जल्दी टेस्ट कराओगे, रिपोर्ट नेगेटिव आएगा, आप समझोगे आप सेफ हो, बेधड़क घूमने लगोगे, फिरने लगोगे, खुश हो जाओगे, पार्टी बनाओगे, बीमार पड़ जाओगे. पार्टी में भी अगर ज्यादा आइसक्रीम कोल्ड ड्रिंक खा लिया, उससे भी इम्यूनिटी डाउन होती है, बीमार पड़ते हैं लोग. आई हैव लिटरली हैड पीपल हु ऑल दे हैव डन रॉन्ग इज दे हैव हैड अ लॉट ऑफ कोल्ड ड्रिंक्स बिकॉज इट वाज समर, and they've reduced their immunity and caught a virus, and now they are going crazy over what happened. Otherwise very healthy. So I think that people have to take even the airborne transmission with a pinch of salt. If you're in a closed space for more than 15 to 30 minutes in a closed environment with air conditioning, with no ventilation, for that duration of time, then consider yourself exposed. Not because someone above you or below you. We have not yet proven that through the ducts and through the vents and through those things this virus can spread. Hasn't yet been conclusively proven. In a closed room, it can transmit even 60 feet. Okay, that has already been shown through airborne transmission. But through these spaces, I don't think people should get paranoid and scared and go for testing. If you're worried that you've been exposed, quarantine yourself, be practical, be realistic. Okay, take care of yourself, take care of your family and everyone else. Wait, if symptoms develop, then go for testing. That would be my advice.
Thank you, Dr. Sitesh. Okay, Bhavna, over to you, please.
Okay. Thank you so much, Dr. Sitesh. बहुत सुंदर presentation, and मैं आपके YouTube को follow कर रही हूँ. So continuously. So एक कुछ questions हमारे आने शुरू हुए हैं. एक Dr. सुनीत माथुर का question है, and he's asking like if RT-PCR test results comes after 3 to 4 days, can we should start taking medicine prescribed like ivermectin, azithromycin, etc. under the protocol, because this is a time, this is a COVID pandemic time, and every fever should be treated as COVID. So should we start that? That's one question from our audience.
So this is a very tricky situation, and even I don't have the perfect answer for this. I'll tell you the truth. Every time I'm faced with it, it's a dilemma. Just a fever, I don't start medications just like that. If there is a clear exposure, there's a positive contact in the house or somewhere else, then I'm more prone to beginning medicines even before the result comes. I always remember in the back of my mind कि डेंगू भी है, मलेरिया भी है, चिकनगुनिया भी है, टाइफॉइड भी है, दूसरी बीमारियां भी है, तो हम इसे इग्नोर नहीं कर सकते. इसमें जैसे मैंने बताया पहले, स्पेक्ट्रम पेशेंट का क्या है, उसका एक्सपोजर क्या है, डू वी नो कहाँ से उसको पकड़ा है, क्या वो किसी कोविड पेशेंट के साथ रह रहा है, ये सारी चीजें वे बैलेंस करके हम दवाई शुरू करते हैं. अगर फिजिशियन का, आपके ट्रीटिंग फिजिशियन का अगर लेवल ऑफ सस्पिशन, अगर ये सवाल ऐसा है कि पेशेंट खुद से जाके आइवरमेक्टिन, डॉक्सीसाइक्लिन खरीद रहा है, तो बहुत ही गलत है, नहीं होना चाहिए. आपके डॉक्टर को अगर हाई लेवल ऑफ सस्पिशन है कि ये पर्सन को ये बीमारी हो सकती है, फिर इट इज एब्सोल्युटली अ क्लिनिकल जजमेंट. कोई आपको गलत नहीं ठहरा सकता अगर आपका सस्पिशन हाई है कि आप वो दवाइयां शुरू करो. अभी इसमें से आई एम होपफुल कि लोगों ने हाइड्रोक्सीक्लोरोक्विन से दूर चले गए हैं. हमारे गाइडलाइंस में आज भी है, मैंने एक बार भी यूज नहीं किया है. डॉक्सीसाइक्लिन आइवरमेक्टिन का कॉम्बिनेशन भी उसका डेटा मिक्स्ड है। फेविपिराविर बोल के एंटीवायरल ड्रग है जो हम जरूर यूज करते हैं। इंडिया में डेटा है, अब्रॉड का डेटा उतना स्ट्रांग नहीं है। क्या आप यूज करोगे, कितने दिनों के लिए यूज करोगे, 5 दिनों के लिए या 7 दिनों के लिए, आइवरमेक्टिन 3 दिनों के लिए, डॉक्सी 5 दिनों के लिए या 7 दिनों के लिए, ये सब एक क्लिनिशियन के जजमेंट पे बेस करता है। पूरा स्पेक्ट्रम वो पेशेंट का। हाई रिस्क पेशेंट है, आप ट्रीटमेंट जल्दी शुरू करोगे। लो रिस्क पेशेंट है, हेल्थी है, फिट है, उसको थोड़ा सा बुखार आया, आपको पता है उसका कोविड अगर आगे भी गया उतना ज्यादा तकलीफ नहीं देगा, आप वेट कर सकते हो 1-2 दिन रिपोर्ट के लिए। लेकिन अगर आपका सस्पिशन हाई है, एक्सपोजर हुआ है, पॉजिटिव कॉन्टैक्ट है, सब है, तो वेट मत कीजिए। तो मेरा ये बोलना है कि हर बुखार के लिए कोविड समझ के इलाज करना भी ओवर ट्रीटमेंट है, एंड इलाज ना करना, रिपोर्ट के लिए वेट करना भी गलत चीज है। ट्रुथ कहीं तो बीच में है, सत्य जो है वो कहीं तो बीच में है, और उसके लिए हम डॉक्टर्स बने हैं। हमारे ऊपर बर्डन, मुझे हर लॉन्ग डिस्टेंस केस जिसको मैं मिल नहीं सकता, बहुत स्ट्रेसफुल होता है मैनेज करने के लिए, बट क्या करें, हमने वो रिस्पॉन्सिबिलिटी लिया है, वो ओथ लिया है, तो हमें करना पड़ेगा। आंसर एकदम सीधा साधा और सरल नहीं है।
एंड थैंक यू सो मच, बिल्कुल क्लियर रहा मेरे ख्याल से डॉक्टर सुनील। शिवानी कहाँ पर एक का क्वेश्चन यहाँ पर है, वो ये पूछ रही हैं कि हर मदर फेस दिस प्रॉब्लम मींस आफ्टर वैक्सीनेशन, कोविड वैक्सीन लगाई उसके बाद में फीवर आया और अभी भी करीब 2 वीक से ज्यादा हो गया है, स्टिल शी इज फेसिंग कोल्ड, कफ एंड वॉमिटिंग। तो ये क्या कंसिडर किया जाए, क्या इसे कोविड कंसिडर करें या फिर ये वैक्सीन का साइड इफेक्ट करके डोज नंबर 1?
ये बहुत वापस ट्रिकी सिचुएशन है। जनरली कोवैक्सिन या कोविशील्ड, ये वैक्सीन के साइड इफेक्ट्स में फीवर भी है, हेडेक भी है, कॉफ जनरली नहीं है साइड इफेक्ट्स में वैक्सीन के। ओके, कॉफ नहीं है, कम केसेस में, रेयर केसेस में हो सकता है। बॉडी पेन है, फटीग है, मायालजिया है, लॉस ऑफ टेस्ट एंड स्मेल नहीं है वैक्सीन के साइड इफेक्ट्स में। ओके, नौशिया, वॉमिटिंग, डायरिया जरूर है। तो आपको फिर से इंडिविजुअल के स्पेक्ट्रम ऑफ सिम्टम्स, अगर खांसी, बुखार, बदन दर्द चल रहा है, आपको इसको कोविड इन्फेक्शन समझना पड़ेगा। अनफॉर्चुनेटली लोगों को वैक्सीन लेने के बाद टाइम नहीं मिलता वैक्सीन से प्रोटेक्ट होने के लिए, जो 4 हफ्ता लगता है। बीच में ही कई बार कोविड वैक्सीनेशन सेंटर में आप 100-200 लोगों के बीच बैठे हो, लाइंस में खड़े हो, फिजिकल डिस्टेंसिंग नहीं है, आप सेंटर में जाके कोविड पकड़ के आ सकते हो अनफॉर्चुनेटली। तो ऐसे सिचुएशन में अगर वैक्सीनेशन के बाद सिम्टम्स काफी सारे हैं, तो इसे कोविड के टेस्टिंग के लिए टेस्टिंग करना बहुत जरूरी है, ब्लड बायोमार्कर्स करना बहुत जरूरी है, मे बी इवन HRCT अगर ये सब नेगेटिव आए, उसको सिर्फ वैक्सीन का साइड इफेक्ट समझ के 15-20 दिन के लिए तो मैं इग्नोर नहीं करूंगा। जबकि मेरे पास केसेस रहे हैं जिनको बदन दर्द 15-20 दिन चला है, जिनको हेडेक 10-12 दिन चला है, जिनको फीवर 5-7 दिन चला है, बट 14, 15, 20 डेज बहुत ज्यादा है। प्लीज इवेल्युएट कीजिए, प्लीज ट्रीट कीजिए।
और एक क्वेश्चन अभी बहुत शॉर्ट सा है सभी के साथ में कि एट द एंड कंक्लूज करने में आप कौन सा टेस्ट सबसे कॉस्ट इफेक्टिव एप्रोप्रिएट मान के चलते हैं? 2-3 स्टूडेंट्स, डॉक्टर स्टेफी फ्रॉम कर्नाटका, चेन्नई, आई थिंक ना, शी हैज आस्क्ड दिस क्वेश्चन. So what is the best appropriate cost effective test still you prefer, and you say that yeah, that is for your people from rural background also and urban, and taking the time like RT-PCR is taking approximately 3 to 4 days.
So frankly, I know coming from a super specialist like me, but I think a lot of doctors who are at the front lines will agree, a simple CBC and a CRP can sometimes tell you more than a rapid antigen test and an RT-PCR can, done at the right time again. Okay. Because there have been people whose CBC and CRP have looked quite okay on day 1 or 2 of illness, but by day 4 of illness have looked terrible, okay, or day 5 of illness. So हर टेस्ट में याद रखना है, रेपिटेशन जरूरी हो सकती है। हम CBC CRP को भी सीरियली फॉलो करते हैं, जैसे पर्सन इंप्रूव होता है या वर्सन हो रहा है, डे 7-8 में अगर बुखार वापस बढ़ गया जो चला गया था, सो वी वरी अबाउट साइटोकाइन स्टॉर्म्स, वी वरी अबाउट इन्फ्लेमेटरी मार्कर्स, and we do more investigations and closer monitoring then. But I would say that simple things always come first. CBC, CRP, LDL, ferritin available है तो रैपिड एंटीजन टेस्ट अवेलेबल हो सकता है रूरल एरियाज में, रिपोर्ट 15 मिनट में आता है अगर सही तरीके से किया जाए। तो प्लीज अपने स्टेट्स को, अपने गवर्नमेंट सिस्टम्स को एक्टिवेट करके ये अवेलेबल कराइए। प्लीज गेट दोस थिंग्स देयर। When RT-PCR is possible, do it. Wait for the report, but your other reports will come soon. Your rapid antigen will come in 15-20 minutes. Your CBC CRP will come within a couple of hours, half a day, at the most 1 day. You can begin your treatment based on all of that, and you can then also serially follow that if you need it. So the cheapest and most economical test, interestingly, is CBC CRP. Remember your neutrophil lymphocyte ratio, invaluable if it is above 3.5, high risk of it being COVID. Not a guaranteed test. CRP is again above normal. Once it crosses a level of 12 or 15 or 20, you know you're dealing with a significant viral infection. Certainly can be other diseases also, like I said, don't ignore those, but these would be best, and then rapid antigen test and the RT-PCR where possible. Pulse oximetry, okay, simple. पब्लिक रूरल हेल्थ सेंटर्स में भी होते हैं आजकल, होने चाहिए, अगर नहीं है तो प्लीज मांगिए, जरूरी है। ऑक्सीजन मेजर करो। ऑक्सीजन, वो दिन मेरे पास एक पेशेंट आया जो अस्थमा का पेशेंट है, उनको लगा उनका अस्थमा फ्लेयर अप हुआ है, मुझे बहुत सालों से देख रहे हैं, उनके घर पे पल्स ऑक्सीमीटर किसी ने दिया था, टूट गया, काम नहीं कर रहा है, मेजर किया, नहीं आ रहा था रीडिंग, आए मेरे पास 66% ऑक्सीजन था उनका, और उनको कोविड के सारे सिम्टम्स थे। उनको इमीडिएटली हमने ट्रांसफर किया राइट सेंटर में, राइट टेस्टिंग किया, ट्रीटमेंट शुरू किया। बट पल्स ऑक्सीमेट्री कैन बी इनवैल्यूएबल इन अ रूरल हेल्थ सेंटर, अगर वो अवेलेबल है। टेम्परेचर मॉनिटरिंग कैन बी इनवैल्यूएबल इन अ रूरल हेल्थ सेंटर, क्योंकि कोविड के फीवर्स जनरली बिगिनिंग में 99.5, 100, 100.5, 100.4, 101 रहते हैं, फिर जब डिजीज प्रोग्रेस होता है 102, 103, 104 तक भी जा सकता है। बट ये फीवर के पैटर्न्स, पल्स ऑक्सीमेट्री के पैटर्न्स, रेस्पिरेटरी रेट, हार्ट रेट, ये सारी चीजें इनवैल्यूएबल टूल्स है रूरल एरियाज में, इंटीरियर्स में इंडिया के। प्लीज यूज कीजिए इनको एंड फॉर्म अ क्लिनिकल पिक्चर। Test is a test, but the clinician is always at the top of their game if they follow these things.
So then the last question I would like to take, Dr. Sachin. So he's asking, dear sir, what after taking vaccine recipient, your experience basically became positive also, and disease becoming severe too. So impact of vaccine basically, COVID vaccine and disease.
So you're saying that after taking, if I understand correctly, after taking vaccine, before the protection was developed, the person became positive, you're saying, or after they took both doses of the vaccine, then they caught the disease again?
This question is not clear, but as far as I understood that कि वैक्सीन लग गया है, अब ये लोग बाद में severity of the disease इन पे आप कैसा ऑब्जर्व कर रहे हो? I hope सचिन यही पूछ रहे हैं।
Okay, I understood वो क्या पूछ रहे हैं। वैक्सीन लगाने के बाद जनरली डिजीज माइल्ड टू मॉडरेट होता है। जिन्होंने अपने 2 डोजेस ले लिए हैं और जिनको कोविड हुआ है, 99% लोगों को माइल्ड टू मॉडरेट ही हुआ है, जितना हमारे ऑब्जर्वेशन में है। एक्चुअली इलिनॉय डिपार्टमेंट ऑफ पब्लिक हेल्थ ने रिसेंटली अपना कुछ डेटा रिलीज किया। उन्होंने अबाउट 700,000 वैक्सीन दिए थे, और उन्होंने उसके अंदर देखा कि जिन लोगों को वैक्सीन लेने के बाद भी कोविड हो गई, वो नंबर, और वो सिवियर इनफ था कि उनको हॉस्पिटलाइज करना पड़ा, वो नंबर बहुत कम था, मतलब 0.some% में, 0.1% के आसपास जिनको हॉस्पिटलाइज करना पड़ा और जिनका केस सिवियर हुआ। और फेटेलिटी 700,000 में से 6 लोगों की थी जो डेथ्स हुए। तो जो भी वैक्सीन बोलता है कि हम 100% फेटेलिटी प्रिवेंट करते हैं, वो सच नहीं है, क्योंकि अगर वो पर्सन को सिवियर डायबिटीज, सिवियर हाइपरटेंशन, सिवियर हार्ट डिजीज, सिवियर बीमारी, पहले का कैंसर इन कीमोथेरेपी, इम्यूनोसप्रेशन, ये सब रिस्क फैक्टर्स है, तो वैक्सीन के बाद भी उनको बैड आउटकम्स हो सकते हैं। लेकिन इवन वो लोग जिनका इम्यून सप्रेशन है या जिनका कैंसर कीमोथेरेपी चालू है, उनको भी वैक्सीन प्रोटेक्शन देता है एटलीस्ट हाफ ऑफ द टाइम्स। तो जरूरी है उनको भी वैक्सीन लेना, और वो वैक्सीन लेकर उनका रिस्क कम होता है कि उनको सिवियर डिजीज होगा, क्योंकि उनके पास कुछ तो प्री फॉर्म्ड एंटीबॉडीज और कुछ तो सेल्यूलर इम्यूनिटी है पहले का। तो मेरा ये कहना है कि जनरली वैक्सीन के बाद डिजीज माइल्ड टू मॉडरेट रहता है, रेयर केसेस में सिवियर होता है, जिनमें सिवियर होता है उनके कोमॉर्बिडिटीज होते हैं, उनको दूसरी बीमारियां होती है जिसके कारण से वो सिवियर हो गए।
ओके, थैंक यू सो मच। और कोई क्वेश्चन? मेरे ख्याल से क्वेश्चन एंड आंसर्स तो हमने कवर कर लिया है। नाउ बिकॉज वी आर टॉकिंग अबाउट वैक्सीन, तो वैक्सीन से रिलेटेड मैं क्वेश्चन पूछना चाहूंगी डॉक्टर आशीष मनोजा। डॉक्टर आशीष, आपने वैक्सीन ड्राइव शुरू करी है अपनी पूर्णिमा यूनिवर्सिटी में
जी।
और अभी रिसेंटली वैक्सीन लगा भी है, अपना कुछ एक्सपीरियंस शेयर करना चाहेंगे आप?
Good evening
Yes.
all, good morning all. I recently got vaccinated and मेरा जो एक्सपीरियंस था वैक्सीन एडमिनिस्टर होने के the same night I got 100.1 fever, बट नेक्स्ट डे तक वो ठीक हो गया था, ऐसा कुछ प्रॉब्लम नहीं गया। एंड एक्सपीरियंस मेरा यही था कि ओनली 2 days थोड़ा प्रॉब्लम रहा, बाकी आई टुक पैरासिटामोल एज प्रिस्क्राइब्ड बाय माय फिजिशियन और ऐसा कोई प्रॉब्लम नहीं गया। Currently, we decided to organize a vaccination drive at Poornima University, Jaipur. So हमें थोड़े challenges face करने पड़ रहे हैं अभी फिलहाल। कुछ challenges ऐसे कि वैक्सीन जो हमारी लॉजिस्टिक इश्यूज हैं अभी भी, जो डिले इन डिलीवरी है या अदर लोकल ट्रिगर्स हैं उस वजह से, एंड देयर आर सम प्रेशर टुवर्ड्स द कॉर्पोरेट्स जो कि प्रायोरिटी वाइज वो चाह रहे हैं कि हमारी वैक्सीनेशन पहले हो, जिस हिसाब से उस हिसाब से हमें लॉजिस्टिक्स नहीं मिल पा रहे हैं। सेकेंडली, हमें कुछ वैक्सीन हेजिटेंसी का भी इशू फेस करना पड़ रहा है। देयर इज पॉसिबल रिजल्ट ऑफ र्यूमर्स हो रहे हैं, कुछ मिस इन्फॉर्मेशन फॉर एंटी वैक्सीनेशन ग्रुप्स बोल सकते हैं आप, एंड कुछ अलग कम्युनिटीज या ऐसा कुछ जोग्राफिकल एरिया है या जो कि बार बार रजिस्ट कर रहे हैं accepting the vaccine and owing to that long standing, जिसको हम बोल सकते हैं aversion to vaccination। तो एक ये हम challenges face कर रहे हैं फिलहाल अभी वैक्सीन हेजिटेंसी के लिए। बट ऑन दी अदर साइड सम पीपल nowadays are getting eager to get vaccinated, क्योंकि अभी जिस हिसाब से सेकेंड वेव हमारा सर्ज पर आया है, उस जो हमारे यूथ को जब इन्होंने अलाउ किया है हमारे गवर्नमेंट कि उनको एडमिनिस्टर करेंगे हम वैक्सीन, उस हिसाब से वैक्सीन ईगरनेस परसेंटेज अगर आप देखेंगे तो वो इंक्रीज हो गई है। एंड आई एम हैप्पी टू शेयर दैट अभी करेंटली अभी हमारे इंडिया ने recently they vaccinated around 16 crores as per the yesterday's data, around 16 crores 49 lakhs they administered the vaccines, and it's you can say that's half of USA, and that's one Russia or 2.5 for UK, whatever, and it's but we are still only 13% done। अभी हमने 13% ही किया है, and we have a long way to go, and we should always appreciate our authorities for the tremendous work, tremendous resilience of our nation to think at this scale।
Great.
Yes ma'am।
Okay, that's great। So meanwhile मुझे दिखे अभी डॉक्टर कंदर्प, मेरे ख्याल से अभी भी he is having some problem now, so Dr. Kandab, are you there?
Yes ma'am। Am I audible?
Yes। Second how are you feeling right now, because you had some nasal bleeding now?
Yeah, so I mean this is my reinfection। मुझे दूसरी बार कोविड का इन्फेक्शन हुआ है। पिछला जो मेरा कोविड इन्फेक्शन था वो अक्टूबर में हुआ था, अक्टूबर 2020 में। ये मेरा रीइन्फेक्शन सेकंड बार हुआ है मुझे। एंड एक चीज मैंने नोटिस की कि जो पहला जो इन्फेक्शन था, पहला इन्फेक्शन जो अक्टूबर में हुआ था, उसमें फीवर बहुत माइल्ड था और उसके अलावा मेजरली कोई सिम्टम्स नहीं थे, ओनली कॉफिंग एंड फीवर वर द सिम्टम्स। बट यहाँ एक बहुत सिग्निफिकेंट चेंज मैंने नोटिस किया है कि ये जो नया वेव आया है, नया स्ट्रेन कह सकते हैं आप, this is giving slightly severe symptoms। I mean if the symptoms were mild in the first infection, the symptoms have become moderate to severe in the second wave। and वही चीज मेरे साथ हुई। मेरा फीवर 16 अप्रैल के आसपास मुझे आया। सिंस इट वाज ओनली फीवर, जैसा सितेश जी ने मुझे बताया, सबको बताया, और मैं बहुत मैं आगे बढ़ने से पहले मैं डॉक्टर सितेश रॉय, डॉक्टर अरविंद माथुर, हमारे पास ऐसी हस्तियां हैं और इतने बड़े लोग हैं जो बहुत काम कर रहे हैं, और आज जो हमारे साथ उन्होंने इंफॉर्मेशन शेयर की है, जो जानकारी हमारे साथ शेयर की है सबके साथ, और देखने वालों को भी मैं यही कहूँगा कि ये बहुत वैल्यूएबल जानकारी है। और काफ़ी मिस इन्फॉर्मेशन फैलाया जा रहा है, आशीष जी ने बताया जैसे कि बहुत मिस इन्फॉर्मेशन फैलाया जा रहा है। मैं सभी से रिक्वेस्ट करूंगा मिस इन्फॉर्मेशन के पचड़े में ना पड़े, हमेशा अपने डॉक्टर की सुने, डॉक्टर जो बोल रहा है उसे बाइबल की तरह मान के चलें इन टाइम्स में, क्योंकि वही आपको स्वस्थ रखेगा। खैर, सेकंड जो इन्फेक्शन है उसमें 16 तारीख को मुझे फीवर आया, सिर्फ फीवर था, इसलिए मैंने, जो डॉक्टर सतेश जी ने कहा कि एक डिलेमा होता है मन में, एक कश्मकश होती है कि क्या कोविड है या नहीं है तो मैंने केवल पैरासिटामोल से स्टार्ट किया। 18th तक आते आते गले में सिम्टम्स आने शुरू हो गए, खाना खाना मुश्किल हो गया, पानी पीना भी मुश्किल हो गया, दर्द होने लग गया काफी। 21st तक आते आते लॉस ऑफ स्मेल और लॉस ऑफ टेस्ट हुआ, तब जाकर मैं आरटीपीसीआर के लिए अगले दिन गया और उसके अगले दिन अनफॉर्चुनेटली पॉजिटिव आ गया। मेरी वाइफ भी साथ में पॉजिटिव आ गई, तो हम दोनों ने इमीडिएटली जैसे ही न्यूज़ मिली हाथों हाथ खुद को अलग क्वारंटीन किया एक रूम में। एंड अब 7 मई को मेरा क्वारंटीन पीरियड ओवर हुआ है। काफ़ी लंबे टाइम तक फीवर रहा। इट वॉज अ वेरी लॉन्ग स्टैंडिंग फीवर ऑफ 7 or 8 days initially from 16 to 23rd, 24th. And recently, 2 days ago, I have contracted fever again. I spit out blood in my cough for some reason. So I again have gone for some blood tests as prescribed by my ENT specialist. So waiting for the results, and I just request everyone that please don't take this lightly. Please don't go out until and unless it is very, very necessary to do so. And the governments are doing their bit, but they can only do so much. अभी गवर्नमेंट इज नॉट, सरकार आपकी जिंदगी के हर पहलू को नहीं चला सकती, कुछ तो आपको भी जिम्मेदारी खुद से उठानी पड़ेगी। एंड जैसे ही आप, मैं सभी से रिक्वेस्ट करूंगा, जैसे ही आपको लगे कि कुछ भी एक भी सिम्टम आ रहा है, इमीडिएटली फर्स्ट थिंग यू डू इज quarantine yourself or isolate yourself, and talk to your doctor immediately, even if you have the slightest of the symptoms or slightest of hint of the symptoms. So इन्हीं शब्दों के साथ मैं सभी से रिक्वेस्ट करूंगा, जो भी देख रहे हैं हमें, जो भी सुन रहे हैं, यहाँ पर जो अटेंडीज हैं, जो फेसबुक पर, यूट्यूब पर, सोशल मीडिया पर हमें देख रहे हैं, आपसे इतनी रिक्वेस्ट है, जो भी गाइडलाइंस आती हैं ऑफिशियल चैनल से, प्लीज उन्हीं पर ध्यान दें, मिस इन्फॉर्मेशन के जाल में ना फंसे। इतना ही मैं रिक्वेस्ट करूंगा। एंड ओवर टू यू मैम। थैंक यू फॉर द अपॉर्चुनिटी।
थैंक यू सो मच। रियल लाइफ एक्सपीरियंस है, मेरे ख्याल से सभी लोगों के पास समझ में आ रही है कि कहाँ गलतियां हो रही हैं, और जो भी डॉक्टर सितेश ने बताया, यहाँ पर एक प्रैक्टिकल एग्जांपल हमारे साथ में था कि कैसे हमने शुरुआत में गलती करी और कैसे हमने फिर देर में हम लोगों ने सिस्टम को आइडेंटिफाई करने के लिए गए। द मोमेंट वी केम टू नो दैट वी हैव स्मेल लॉस, यस, बट द मैसेज रियली वेरी क्लियर. And now we are also having one more panelist, Dr. Full Kalla. डॉक्टर कल्ला जो है उन्हें भी रिसेंटली इन्फेक्शन अभी हुआ है। बाय ट्रेनिंग ये भी डेंटिस्ट है और एक बहुत अच्छे मुझे स्कॉलर नजर आते हैं, क्योंकि एज अ स्टूडेंट मैं काफी अप्रिशिएट किया करती थी, एंड इंटर्न भी रहे हमारे साथ में। सो अभी राइट नाउ ही इज वर्किंग विद इंश्योरेंस सेक्टर इन। सो डॉक्टर कल्ला, आप हैं अभी यहाँ पे? अरे देयर? यस डॉक्टर कल्ला। सो अब मुझे ये अपना एक्सपीरियंस बताइए कि पहले आपका एक्सपीरियंस क्या रहा, नंबर 1, क्या इंपॉर्टेंट मैसेज आप देना चाहते हैं ऑडियंस को, एंड तीसरी चीज इंश्योरेंस सेक्टर, क्योंकि आपसे हमेशा यही क्वेश्चन रहेगा कि इंश्योरेंस सेक्टर हमें क्या मदद कर पा रहा है ड्यूरिंग दिस टाइम, पेंडेमिक क्या इंक्लूड होता है, नहीं, एक्सेट्रा एक्सेट्रा। सो मुझे ये 2-3 क्वेश्चंस के मैंने इकट्ठे पूछ डाले हैं, तो मुझे इसका एक आंसर प्लीज शेयर करिएगा।
Sure. Good evening, Bhavana. It's lovely to connect you again, with you again. And thanks, Dr. Anil Sir and JSPH and Poornima University for inviting me back again. Last time I was there in August 2020. So recently, around 8th of April, I got contracted from COVID, and I was having symptoms with some cough, sore throat, and a fever. Fever of I got it around at midnight time, and specifically it was a high grade fever. So I'm happy that there are doctors around me, family doctors are around me, that instantly told me to get a COVID test done. I think within one day I got the test done. And so one thing I want to tell everyone is, if you feel anything, certain symptoms of like seasonal symptoms, just like COVID, okay, get yourself tested. Just for the sake that at least if you have that facility, because in the rural parts of India, some there or there's some lackage, there could be some issues. Some points I want to add personally is that key that in the rural part of the tier 2 cities or tier 3 cities, there are some limited RT-PCR kits. So around the month of end of March, we had a limited supply and procurement around the states. Okay, and this wave came, and wave actually exposed the whole scenario and the overall India part. So I will just quote my dean, now my ex-dean, Dr. Sundaraman, okay, who was the founding member of NHSRC. So I will just text him, like he just told a few days back, is that COVID have just, this second COVID wave have just exposed the Indian public health infrastructure, only now seen by the, because it is now only seen by the middle class or the upper middle class people or the rich class people. It actually was it was all suffered by the poor people. So that is the reason we have just seen that it is the infrastructure, oxygen supply, all the things, poor medical amenities, we have just seen it right now. But I personally feel it was already there, and I think the all public health schools and all the public health specialists will try to work out, and will also think about, all the doctors, frontline workers will think about all the same thing. So coming back to my COVID part, I had a here I will this platform I will specially thank Dr. Arvind Mathur sir. So he was my treating physician. He might have not connected because he was directly talking to my uncle, and but I will definitely thank him that because of him I got recovered within that 10 days period. As so I thank you, Dr. Arvind sir. I couldn't connect you afterwards. So as a patient, as a I think junior also, I'll just thank you for the same. So yeah. So one thing I wanted to know is that I got a Covishield first dose of my vaccination jab on 21st April. After around 15 days, I think many of the participants had that question, is that post vaccination also, could you get it? But yes, you can get it, because the antibodies, as per my knowledge, take some time to form. Some bodies might form it, some might not. It's usually connected with the fever part that your body reacts to it, and somehow it is get to the certain part. So first thing is that. Second is the vaccination, as Dr. Sitesh told us, that severity basically reduces. So it could be the mild or moderate case. In my case, I had around 7 to 8 days of fever, but that fever was broke down from 103 to around 100 degree. So the major I had is the muscle weakness, muscle fatigue, whole weakness, and the throat was gone. Only the fever was there, and all the things were getting time to time getting better. And only the I think I am having is the residual cough. The residual cough, which is getting into the part, is I think it will take around 2 or 3 days or around 5 days. So I'm regularly taking steam on that. So so that was my COVID experience, and I successfully got recovered. And now getting into the vaccination part and the insurance part. Now why I connected to the vaccination is that as organizations, our team is also contributing pan India for ICICI Group, the Lombard Securities, and potentials to get the vaccination done. Yes, there is a procurement issue when the government declared for 18 to 44 age years. So when the step was taken, the supply was comparatively less. Procurement and the making of it was comparatively less. So what had happened is the action was taken later, but the decision was made earlier. So that concurrence, that angle has been an issue for Pan India. So the supply issue is creating for the corporate as well. And for the insurance, as the IDA says, is that for all the cashless hospitalization, we are bound to provide them within 1 to 2 hours. And all the retail corporate policies, all the people who are getting hospitalized, for example, Medipus Hospital in Jodhpur and all, okay, Pan India. So these are the things we are getting the thing in within timely manner.
That's great. That's great.
Yes, ma'am.
Yeah, that's good. So, any question for Dr. Praful? Because Jagdish?
Yes, ma'am.
Yeah, any question for Dr. Praful? Jagdish is there? Okay. Anyways, thank you so much, Dr. Kalla. And now we are done as far as questions are concerned, but there is one question I can see right now. It is again by Dr. Sumit, I think. Is there any relevance of taking prophylaxis after vaccination with the rising number of new variants coming in news? This question is for Dr. Sitesh.
There is, so this is my favorite topic, because as an immunologist, right from the beginning of the pandemic, people tell me, Dr. Roy, tell us that magic medicine that will keep our immunity strong, that will make us safe from getting this COVID. Firstly, there is no prophylactic drug at this point of time in the world.
Okay. I think.
You hear me? Hello?
Yeah.
Hello?
You are here. Yeah. We can hear you.
Okay.
Yeah, we lost you for a minute. We can hear you.
So I was saying that there is no prophylactic drug at this point of time that has been approved or is recommended to be used after getting exposed to a patient with COVID-19. Okay. Having said that, people have considered whether favipiravir could be used like people use oseltamivir after getting exposed to influenza. But those studies are in progress. There is no data on that right now. And I certainly am not recommending it to anyone at this point of time. The only prophylaxis that this virus is teaching us is taking care of ourselves. Healthy diet, healthy lifestyle, daily exercise, prayer, meditation, getting fresh air, sunlight. These are the best immune boosters. And if a person takes care of their immunity on a regular basis, they will not have to worry, because most people who I have known who have taken good care of themselves, and I'm not talking about, I don't know whether you all heard about this, but there were big bodybuilders died in this week. So for me, physical fitness is not equal to wellness. I'm talking about wellness, good body, spirit, that says of health. If a person follows all those things, that is the best prophylaxis that they can against this virus. And eventually this virus will become like the other viruses that are in circulation in our community. At one time, influenza killed 5 crore people around between 1918 and 1920. Today, influenza kills about 5 lakh people around the world every year. But we never talk about it. So the point to remember is we have to work on our own immune systems, our own diet, our own lifestyle, our own health. And that's the only way we can be immune to this virus. Vaccinations will help, timely treatments will help, testing will help. But the final answer is you have to wake up and take care of yourself. stressors, anxiety, wrong diet, wrong lifestyle, all of these things, and then that leading to comorbid diseases. Uh, all of those things are showing us, the virus is showing us all the chinks in our armor and telling us where we have to become smarter. Those who already have the issues, not much can be done. Those who don't have it, also they their diet, lifestyle, and do different things so they stay safe. Now, no variant. There are 7,000 registered mutants of the SARS around the world. 17,000. We talk about the UK variant, the South African variant, the Brazilian variant, the Indian double mutant, the Indian triple mutant. These are just a few. This virus, remember, lives with bats in caves for hundreds of years. And the bat's immune system is so adapted. The moment the virus in within remove, so we will or we will community virus will happen, but we have to just separate profile.
I think we're losing you, Dr. Roy.
Yeah,
Okay.
I think there's some problem in the internet.
Yeah. Right. So,
Okay. Can you all hear me now?
Now,
we can-
yes.
Great.
Okay.
So,
Okay. I hope I all heard. I think the last what I said is the important message.
I think there's an internet issue.
Okay. Okay.
Dr. Mathur, any comments before we close?
My last question is to Dr. Mathur. Do you suggest any kind of vaccine like flu vaccine, pneumococcal vaccine to diabetic patients or any other who are vulnerable basically as far as this COVID period is concerned?
I think in COVID period also, those who are vulnerable, they should have their routine vaccination done, both pneumococcal or flu vaccine, particularly for chronic obstructive lung disease or diabetics or so. And Dr. Sitesh has very clearly defined everything. And one question which was there on the chat box was of having disease after vaccination. And I tell you, I've been seeing now frequently in our city many persons coming with positive disease and a positive test after 10 or 15 days of what they say that they had their vaccination. They were all right for 7-8 days or 10 days, and then they started having this problem. And they test positive and they have the disease also. Now, what I feel that it is definitely not related with the vaccination itself, but the way they went out for getting their vaccine, they got themselves exposed. So the old person who was there in house for all these months, suddenly is taken out for vaccination. I'm pretty sure that the way they use masks, etc., protection is
Yes.
not there. So they get exposed, and then after just according to the incubation period, after 5-6 days, 7 days, they come with the fever or so. So that is one thing which we have to tell people, because
Yes.
they other the misconception which is being floated probably on social media, that you should not get the vaccine has led to a positive RT-PCR test, which is absolutely incorrect, basically.
Yes.
So, I think with Dr. Roy, I would really be talking to him again regarding the therapies which you have been using, because when we say that we'll be treating these patients, I find that we have got limited things to offer to the patients. But here I like to tell that to the masses, one should tell them that though we have got fewer drugs, but the important point is the time when they have to be used. That is very crucial and critical, because if used at a wrong time, they will cause harm. And that's what we have been seeing, that on day one, somebody getting the whole prescription of 10, 15 drugs, whatever is being named for COVID is prescribed on day one. That is not the important thing. Here, the importance lies in selecting the day when you have to introduce that drug or to discontinue that particular drug. So that is one important message, because I've seen patients taking azithromycin, doxycycline, ivermectin, steroid, as whatever is there is from day one with favipiravir and everything. They'll start with that. So that is over use of these drugs, and use of drugs at wrong time is also important to be realized. So that is one thing. We have got now, Dr. Roy, I just cannot resist asking you about what has been your experience about using baricitinib or colchicine? Because I feel that out of, besides remdesivir, uh, colchicine also is one simple drug which could be used for this purpose. And if yes, when do you think it is better? It is for my personal
So
interest.
sure. No, certainly.
Mm.
Colchicine, I feel, is a very useful drug, especially in patients who are beyond day 7 or 8 and they're still having high fevers. Colchicine seems to be a fairly useful medication to be used for 5 or 7 days. Fairly safe, requires the blood count monitoring and a couple of other things which we anyways are doing for these patients who are not getting well. The other, the baricitinib, I have not used much, have not had much success with it, haven't been convinced with the data too much, and not very reassuring for me in terms of what I have seen it do. For that matter, even with things like tocilizumab, I have used very little of it really, and I feel it does more harm than good. It has a very narrow window of when it can be used, and between all of those things, I just feel that staying with the standard line of treatment with monitoring and guidance is far better in my opinion. So colchicine is a yes in selected cases, and I think there's enough data now from around the world suggesting that it does help. I think it's even in the US guidelines in some places. We don't have it in our Indian guidelines yet, but I think it may come in the future. But I feel that it is a useful drug, and in select cases, it can make a difference, especially the ones where the fever is persistent day 8, day 10, day 12. It makes a difference.
I think it is easy to use it also in our setting also.
Correct.
Regarding the JAK inhibitor, etc., they will need to be given in hospitalized or institutionalized.
Exactly. That is only in the hospital setting.
For, but colchicine is very simple drug which we can think of using. That's so
And
that
and and though the even for colchicine, the recommendation has been inpatient in a country like India where we have so much of bed shortages and this and that and everything. I think colchicine could potentially be used outpatient also. But the use so far has been such that it has been in hospitalized patients again. So, but I think in India we are doing all kinds of things out of the hospital right now, right from people moving around with oxygen cylinders and concentrators, which is unimaginable for someone who trained and worked in the US, but we've had to do it to keep people alive. So I think we do what we need to.
thank you very much. Yes.
I think thank you so much, Dr. Roy. It was a wonderful session, and thanks to all the panelists. I just have one message for Dr. Roy from Department of Cardiology at Harvard Medical School. Dr. Roy's very good presentation, comprehensive and thorough. So just a
Thank you
compliment,
very much.
which
Thank
makes
you
us
very
happy
much.
too. Thanks.
Thank you.
So thank you all, everybody, and we have gone over time, and I hope everybody feels better, especially Kandar Praful, and hope we have a better day tomorrow. And we've lost a lot of lives, and I think we can only hope and pray that this doesn't continue anymore. And we all are together in this, and I think we will surely get through this, and we will celebrate one day to fight against the virus. So thank you all, and good evening in India, and we will touch base again very soon. Thanks.
Just one last message: plant trees. They are our external lungs.
And I'll request everyone to please switch on the cameras. We'll have
Oh, sorry, I forgot that.
group
Yeah, okay,
picture.
Bhupesh.
We'll have a group
Yeah.
picture just to keep the memories of this webinar. Sitesh, thank you very much. Thanks a lot, everyone.
Thanks. Thanks.
Thank you.
Have a nice evening.
Thank you, everyone. Bye bye. Good day.
Thank you.
Thank you, everyone.
Thank you very much. Thank you very much. Bye.